in the mid-1980s, there was a World Health Organization ladder kind of starting to focus on pain and cancer pain in particular, and they established a prescribing guideline starting with non-opioid medications for mild pain, but leading to moderate severe pain, opioids were warranted. People began to extrapolate that prescribing pattern to non-cancer pain conditions. So now arthritis or other conditions were being treated with opioids if the pain was moderate to severe. And then in the 1990s, there was a huge push focusing on pain and mitigating suffering in patients with chronic pain, and they pushed for pain to become the fifth vital sign. The problem with pain being a vital sign, it is subjective. So as opposed to blood pressure, heart rate, temperature, which are all very objective measures, pain is 100% subjective. And I see it clinically every day where people come in and report pain of 15 out of 10 or 30 out of 10, and their blood pressure, heart rate is all normal, and it's very hard to know what to do with that information and how to process that. Once pain become established, as an emphasis in us addressing it, and there was even some patient satisfaction and monetary aspects associated with that, people started to address it more thoroughly. And in the 1990s, pharmaceutical companies saw an opportunity with this emphasis, and they began marketing some medications that were potentially less addictive, and that was extended release medications, particularly OxyContin. And that just was not the case. And part of that false, advertising is what we're seeing now. So when people said that medications were less addictive because they were extended release, obviously that wasn't true, and we know that the chemistry of the brain with opioids increasing dopamine, that it is going to crave that more and more. And so if you are exposed to it for longer with an extended release option, when that goes away, the withdrawal, the craving remains even greater, as opposed to short-acting medications. When you think of all of the innovations in healthcare and how much we're improving healthcare across the board, opioid addiction is one of the few things that is only getting worse. Typically not one pill, but yes, one prescription. And that, I think, was another issue that people did not address. They thought that people without a history of substance abuse or without a family history of substance abuse weren't at risk for opioid addiction. But clearly that's not the case. We know that a significant percentage of patients begin an opioid addiction perhaps after surgery when they do require opioids, and they get hooked with just one prescription. And again, we always say that there's no face to this epidemic. Again, it transgresses through all ages, all genders, all ethnicities, all aspects of our socioeconomic structure. Well, when you look at the statistics as far as who becomes addicted or where they get the medications from, about 25% use their medications from prescriptions that they're obtaining from a prescribing practitioner. Another quarter of people are getting those medications for free from friends or relatives, and about another 25% are buying those medications from friends or relatives. So over 2/3 of opioid use is getting it non-medically from a friend or relative or utilizing some of their own prescription. Only a small amount actually get that medication from a quote-unquote drug dealer. That's only about 15% of all opioid misuse.
Just like anything else in medicine, I think we have to tailor the treatment to the individual while we engage in a motivational interview with the patient or the person who suffers from chronic pain, trying to understand their needs. What are your goals if we can manage your pain a little bit better? And sometimes they'll be very simple goals. Some people just want to sit through a church service, without having excruciating pain. Some people want to be able to walk to the mailbox at the end of their driveway with their grandchild on a daily basis. They're not able to do that. So there are some simple things that can be done as long as we, as clinicians, align our goals with the goals of the patient, because then you'll get engagement on their part. They'll be willing to take the extra step and go the extra mile and continue to step up their level of function to meet their own goals, because these are their goals. And we do definitely have to move away from treating pain based on a number, because that number varies from individual to individual. My 5 out of 10 would be very different from your 5 out of 10. So we have to take that into account and move away from that treating to the number to treating to what are your functional goals. I think when we talk about the opioid epidemic, we have to probably realize that this is the tip of the iceberg for really a chronic pain epidemic. So when you think about anyone you might know, and probably you know someone, everybody that could be listening out there probably is aware of someone that deals with chronic pain on a daily basis. And you can see that the characteristics of such a person are that they seem withdrawn, they seem depressed all the time, they can't be active, they may choose not to interact with their friends or families, they may not be very effective at work, if they work at all. And so they're significantly functionally limited, and that sets off a vicious cycle of feeling bad, hurting all the time, withdrawing, which makes you isolated, and that feeds the problem of struggling with dealing with this disease. A report released by the Institute of Medicine several years ago that suggested about 100 million people only in the United States suffer from chronic pain. 100 million. That's more people than diabetes, heart disease, and cancer combined, at a cost to our country of about anywhere between $585 to $635 billion. So it's a huge dent in not only for the treatment and the medications, the physical therapy, and other modalities that are required for dealing with this disease, but also with the withdrawal from the workforce, inability to provide from your family, and of course, chronic pain is the #1 reason that people seek disability. So when they get stuck in this vicious cycle and they withdraw and they can no longer work, can you imagine that the impact that this would have on their families? So now you may or may not be the primary breadwinner for your family. You are not able to support your children. They have lost opportunities to be able to get the best education or the best in terms of resources. And we know that low socioeconomics is also a contributing and perhaps a risk factor for developing chronic pain.